Hey everyone, welcome back. Ready to dive into something pretty fascinating today.
Absolutely. Always ready for a good deep dive.
We're tackling Legg-Perthes disease.
Ah, interesting one. We've come a long way in how we think about managing this condition, especially when it comes to orthopedics.
Right. It's amazing how much things have changed. I mean, we're
Yeah.
talking about a disease that for years meant kids stuck in bed for months on end. Can you imagine?
It's true. The old school approach was all about immobilization, bed rest, slings, you name it.
And the thinking behind that was,
Well, the way they understood it, the blood supply to the femoral head, that ball-shaped part of the thigh bone that fits into the hip socket, was getting disrupted. This lack of blood flow was causing damage to the bone, making it weak and prone to, well, basically going a bit haywire during growth.
so like putting the brakes on any movement was the logical solution, right?
Exactly. The less weight and pressure on the hip joint, the better, they thought. It was all about giving that bone a chance to, hopefully, heal without any additional stress.
Makes sense in a way, looking back with the knowledge they had at the time. But thankfully, we've learned a lot since then.
We have indeed.
Our understanding of the disease process has evolved,
Yeah.
and that's reflected in how we manage it today. I mean, now we're talking about controlled weight bearing, even encouraging movement within specific parameters. And then there's this whole concept of abduction, holding the leg out to the side at a specific angle. It's fascinating.
It is. It's a perfect example of how biomechanics play such a crucial role in orthopedic management.
So break it down for us. Why the specific angle?
Okay, so picture this. You've got the femoral head, that ball we were talking about, sitting in the hip socket. Now, with Legg-Perthes, that ball is a bit, well, let's just say it's not perfectly smooth. And because of the way the hip joint is structured, when you keep the leg straight, there's more pressure on certain areas of that ball.
Okay, I'm starting to see where you're going with this.
Right. So by abducting the leg, by moving it out to the side, ideally at around 45 degrees, you're essentially shifting the weight-bearing area of the femoral head. You're creating more contact between the healthy cartilage surfaces of the ball and socket. It's like finding that sweet spot where the pressure is distributed more evenly.
So it's all about maximizing that contact to promote optimal healing.
Precisely. If the angle's off, you risk uneven pressure, and that can lead to deformities down the line as the bone heals.
Got it. So it's not just about keeping the weight off. It's about controlled weight bearing with the leg in the right position.
Exactly. And that's where bracing comes in.
Ah, yes. Braces.
Wow.
And speaking of braces, we've got to talk about the Scottish-Rite and Toronto braces.
Classics, each with its own unique way of addressing that need for abduction and controlled movement.
They look pretty different, though, I have to say. The Scottish-Rite with that bar connecting the thigh cuffs,
Yeah.
it's kind of hard to miss.
Yeah, it's definitely got that memorable look, but hey, it gets the job done. The Scottish-Rite brace, sometimes called the Atlanta hip abduction orthosis, allows for hip flexion and extension, meaning the child can still bend and straighten their leg.
Which is huge for, being able to move around a bit.
Absolutely, and to walk, they have to swing their legs outward in this kind of, well, some might say it resembles a bit of a duck waddle, but that's actually the point.
Right.
Oh, yeah. That waddle, the outward rotation of the leg, it encourages external rotation of the hip, and this helps to position the femoral head properly within the socket.
So the brace itself is kind of dictating the movement they need for healing. Pretty ingenious.
Right, but there's a bit of a trade-off with the Scottish-Rite orthosis. While it's great for that external rotation, it doesn't really control internal rotation.
Ah, and I'm guessing that's where the Toronto brace comes in.
You got it. The Toronto brace is like the heavy-duty, no-nonsense option for hip control. It's a KA-OFO, which stands for knee, ankle, foot orthosis. Basically, it goes from thigh to toe, providing maximum support and control.
That explains why it looks so much bulkier compared to the Scottish-Rite.
Exactly. It might not win any fashion awards, but when it comes to ensuring that femoral head stays put and rotates properly, the Toronto brace is the go-to. It has these foot blocks that force the feet outward, and that outward pressure creates internal rotation of the femoral head.
So it's like a chain reaction, all stemming from the positioning of the feet. Fascinating how these braces work. But it sounds like there are times when bracing alone isn't enough.
Unfortunately, that's true. Some cases of Legg-Perthes are more severe and might require surgical intervention to correct the alignment of the hip joint.
And one procedure that our sources highlighted was the intertrochanteric varus osteotomy. I'll be honest, the name alone sounds a tad intimidating.
I can see how it might sound a little scary, but it's actually a very elegant procedure. Basically, surgeons go in and reshape the thigh bone, the femur, to improve how the ball and socket of the hip joint fit together.
So it's like giving the bone a little bit of a realignment to encourage optimal healing.
Exactly. They're not removing anything, just strategically cutting and repositioning the bone to create a better angle. It's like fine-tuning the mechanics of the hip joint to minimize wear and tear and give the best chance for long-term health.
It really highlights how important early diagnosis and treatment are in these cases, doesn't it?
Absolutely. Early intervention is crucial when it comes to Legg-Perthes. The earlier we can identify it and implement the right treatment plan, whether it's bracing, physical therapy, or in some cases, surgery, the better the long-term outcome for the child.
And speaking of outcomes, are there any long-term concerns for kids who've had Legg-Perthes even with these treatments?
Well, that's the thing about Legg-Perthes. It can increase the risk of certain complications down the line, even with appropriate treatment.
Like what?
Well, one is something called coxa plana, where the femoral head, that ball-shaped part of the joint, can become flattened. And then there's subluxation, which basically means the hip joint is a bit loose, not as stable as it should be.
And both of those can lead to
Osteoarthritis, which is essentially wear and tear on the joint. It's like the cartilage, that smooth cushion between the bones, starts to wear down, leading to pain, stiffness, and reduced mobility over time.
Wow, that's a lot to consider.
Yeah.
It really puts the importance of early intervention into perspective, doesn't it?
It really does. Catching it early gives us the best shot at minimizing those risks and giving these kids the best possible chance at a healthy, active future.
Well said. It's amazing how far we've come, from immobilizing kids for months to these targeted, biomechanically sound approaches. It really makes you wonder, what's next for Legg-Perthes management? What does the future hold?
It's an exciting time. I think we're on the cusp of some incredible breakthroughs, honestly.
Like what? Give us a sneak peek.
Oh, I can't give away all the secrets, but let's just say that researchers are exploring some really promising avenues. We're talking about advancements in drug therapies that could help regenerate damaged bone, even gene therapies that could address the root causes of the disease.
Wow, those sound like game changers. So while we've made great strides, the future of Legg-Perthes management seems even brighter.
Absolutely. And that's something worth being excited about.
Couldn't agree more. And to everyone listening, thank you for joining us on this incredible journey into the world of Legg-Perthes disease. We've gone from bed rest to the forefront of orthopedic innovation, and it's clear that the future holds even more hope for children facing this condition. Until next time, keep those brains curious and those bodies moving.